All right, so welcome everyone. Today it's really my great pleasure to introduce today's speaker, Dr. Jagpreet Chhatwal from Harvard Medical School. He is the director of the Institute of Technology Assessment at Mass General Hospital, and he has done a lot of great work in mathematical modeling, used those analytical tools to inform important policy makings. And his work has been featured in many leading medias like CNN, NPR's. Okay, so I'll stop reading his bios that we have that in the flyer. I'll say something a little bit different. Okay, so although he's from medical school side, from the health policy side, but he's deeply rooted in our informed society. He has a very unique career path. Had a ORIE background, but choose to do more modeling work in the health policy side. So. And also on the personal note, I've been knowing Jag, I've been working with Jag for a long time, and it's been always great research questions to work together, and also appreciate the mentorship and the friendship as well. And today he's going to share with us about his experience from slightly different perspective other than the technical side of the modeling works, and to see how we can maximize our impact for work on the policy side. So without further ado, Jack, please take it away.
Oh, thank you, Choshi and Lauren, for this great opportunity and invitation. I'm very excited to share my journey, starting from IE undergrad to what I'm doing now. So this will be somewhat an unusual talk you would have seen, and also an unusual talk that I have given, in a sense that I'll be more talking about the journey itself rather than presenting the methodology, the problems, but just telling a story, what motivated me, how different opportunities came, what lessons I learned over time, and then anything that I can share back with people, especially with juniors who are starting their career, and that I'll be happy. That'll be an honor if people get to see some directions from my path so far. So let me share my screen. Hopefully it will work fine. Good.
That's perfect.
Okay. So I'll be talking about the topic is it's wide, like modeling to health policy impact, and then how one can increase the impact of the work that we do in the society. Let me see. Okay. So my background, as Choshi was explaining, is in IE undergrad from India, came to the US, got my master's in industrial engineering from Iowa State University, and then in Wisconsin, that's where I got my PhD in, again, industrial engineering and systems engineering. And that was in Wisconsin. That's where I first got exposed to health applications work. I started in optimization, but something I wanted to do was more on the human side. And I got stumbled into this opportunity, and that was like a wow factor for me. And my thesis was on breast cancer machine learning at that time. Moving forward, my interest was in academia, and I was a little confused about where should I apply. I could apply to industrial engineering, business schools, medical schools, and I started applying everywhere, all different paths, and just getting out of PhD. And what happened was I found where I landed was this opportunity at Merck as a health economist in the Merck Research Labs, which I never considered as a PhD student I would be working in a pharmaceutical company at that time. But it just happened that I was the only opportunity I had when I was graduating from my PhD. So I took it. I didn't have any choice. The decision was easy for me. From there, I kept applying for academia. I felt that this is where I want to be. And it took me 3 years to find my first academic job as an assistant professor. And that was in the University of Pittsburgh in Health Policy School. And in fact, in those 3 years, things became clear to me what I want to do. And I ruled out business schools. I don't want to work in business schools. Industrial engineering at also some point, I was still considering, but I ruled out because my heart was more on the applied side, on the health policy side. And I thought public health schools or medical school will be a good fit, and they would like or take the work that I am interested in doing. So there was more alignment happening with my interest in what a medical school or a public health school will would like faculty to do. So that's how I started my journey in Pittsburgh. And then from there, I moved on to MD Anderson Cancer Center for a few years. And then a couple of years I spent there. And then for the last almost 8 years, I've been at Harvard Medical School and Mass General Hospital. And then today I'll talk about mainly two topics, projects on hepatitis C elimination and COVID-19 mitigation. So I'll share my experiences through these two projects. I'll focus primarily on hepatitis C elimination, what opportunities came, what lessons I learned, and then time permitted, I'll go deep dive into the COVID as well. So my question, that's something that has helped me, I'm going to pose this, is that always from the beginning of my career, I kept asking this question, was why I'm doing what I'm doing. So that helped me as a graduate student, that question was there. And that helped me change the trajectory in my own PhD thesis. I wanted to be more on the health application side. The answers at that time were change my area. And then after, during the PhD that I was working on some papers, again, these questions were helpful. And the answers were, depending on what stage I was at, the answers were different. And I had to be very honest, is that I may not like the answer, but the answer helped me take my next step. If I want to change anything in my trajectory, should I do that now or not? And that helped me change my trajectory into like, I want to be more on the applied work and where it could have an impact. That was the answer that I got at that time. And this is what I would say, that it's the question that we all should be asking over and over again. And depending on what stage of our career, it could be the answer is that, yes, I want to get, especially if like somebody is in junior faculty, the answer may be, I'm doing this because I want to get a tenure, or I'm doing this because I want to be promoted to full professor, or maybe I'm doing this because that's what I've been doing this for the last 5-10 years and I'll continue doing this. So whatever that answer is, that helps us give more weight to how we want to spend our academic life. We all have limited time, 24 hours. Within that, maybe 8 hours or so we work per day. How we want to use that time, and is that something that we really want to use that time on? Or is it that I'm mainly doing this just because there's some external factor, like I have to satisfy this tenure promotion committee or some other committee, or really I'm doing this because I'm enjoying doing this and because I really want to do that. So that's the question that helped me, and that led me to the journey, how I started. And I stumbled into this hepatitis C elimination project. It was just by it happened. It could have been any other project, but at that time, I got involved into the Hep C elimination while working as a health economist at Merck, even before I started my academic journey. So once I moved to Pittsburgh, I continued working on that, the Hep C elimination. So I'll walk you through the path, but before that, I just want to give some context about Hep C work. It's an infectious disease. Worldwide, more than 70 million people have been chronically infected. It's a leading cause for liver cancer and the leading indication for liver transplantation in most countries in the world. In the US, now we have approximately 2 million people infected with chronic hepatitis C. And a big majority, not majority, but big proportion of them are still unaware of the disease. It's a slow process. Many people remain unaware until they are in late stages. And then we're talking about Hep C elimination. First, what do I mean by elimination? There's a specific definition, and which came from the World Health Assembly. They pledged to eliminate hepatitis C as a public health threat. It's not eradication, but elimination as a public health threat. And they have specific metric, like reducing the incidence by 80%, mortality by 65%, and then increasing the diagnosis coverage or treatment rates by 90 and 80%. And the World Health Organization also then is following this definition, and they're working on eliminating hepatitis C in all different countries. So a little more background why we're talking about hepatitis C elimination. It's a brief timeline that's showing what is the importance of hepatitis C elimination, why it's relevant today or 5 years back when I started working on this project. So this is just a brief history of different treatments for hepatitis C. So until 2011, the treatments were these combinations of two drugs, peginterferon and ribavirin. The duration of the treatment was 6 months to 12 months with weekly injections. And with a lot of side effects, flu-like symptoms. Imagine if somebody's having flu for entire 1 year. They had to take time off from work, and then going through that, so much decrement in the quality of life. And at the end of 1 year, the chances of having a successful treatment is less than 50%. If you're not treated again, you still have virus, then many people would take another year off and start the treatment. That was the story for a long time, the treatment. But things started changing 2011 onwards. We had the first new generation of drugs became available. And then screening policies also started changing in the US. The major breakthrough happened in 2014 with the second generation direct acting antivirals, DAAs. And basically by 2015, what we had was these combination drugs. It's all oral, take 1 pill a day for 8 weeks to 12 weeks. And with more than 95% success, people would get rid of the virus. So see how much difference may happen in the last 4 or 5 years. It's from almost 1 year-long treatment to 8 to 12 weeks treatment with 95% success. So this was no less than a miracle for people living with hepatitis C. There was so much excitement, enthusiasm that started happening. Okay, everybody now who's want to get treatment. It's the end of 2015 and 2016 onwards. There's so many people who already had been diagnosed. They wanted treatment. And that gave us the first opportunity. This was my first project as a faculty in Pittsburgh in the School of Public Health. What is going to happen now with this drug treatments available, with the updates in the screening policy? We projected that the burden of hepatitis C is going down substantially. The model was extensively validated with external surveys and the CDC data. And then what we showed was, interesting finding was that by 2035, Hep C can become a rare disease. And we published these findings in the Annals of Internal Medicine. It's one of the leading journals with impact factor of more than 50 now. So that caught a lot of attention, like for a disease which is an epidemic, can be a rare disease in over span of next 20 years or so, 25 years. This was widely picked by media to my surprise, leading news channels or the print media. But there was something about this drug that is the people started talking about at some point. Earlier was not really, people didn't pay attention. That was the cost of treatment with the new drugs. It's this like 1 pill a day for 12 weeks. It's like for 84 days, you take this, but each pill costs $1,000. And that was like a big shock factor to many people. How can a pill like this, like my laptop costs $1,000 and this 1 pill and then taking this for like next 84 days. But overall treatment, if you look at from the other perspective, $84,000 for a treatment, which has a cure, is probably a price many people may want to pay. And from patients' perspective, because we have so many cancer drugs which cost more than $100,000 with marginal improvements in treatment. So there was another perspective also happening. But then obviously the question was, is this $1,000 pill justified? There's so much stories started coming up in the media that was widely discussed. And there were also like in the patient groups, there were like some protests happening. This is an interesting one where you see this $1,000 bill and the person, you see the photo is the CEO of Gilead Sciences, which manufactured that drug. So it became a very, it's a question like, is the price right or not? So right at that time, we jumped into this question of looking at the cost effectiveness of treatment. And interestingly, we found that treatment is highly cost effective because this is like, it's a cure for a disease, which earlier was so, it's like a death sentence if people don't get treated. Liver is going to fail at some point, and then there's not many options except liver transplant after that. It's highly cost effective, but budget was the constraint here. Like it's, most people may not be able to afford that budget. So that's for that. I was interviewed by the Wall Street Journal at that time as a young faculty, and I got very excited. Wow, this is an interesting interview. And then I was quite nervous. One of the first interviews with the leading journal. I spent 1 hour talking with the reporter. It became a very interesting conversation. I had to explain to them what cost effectiveness really means, what incremental cost effectiveness ratio means, how do we determine something is cost effective or not. But it became a very nice conversation. At the end of the conversation, I remember the reporter said, "Oh, this is the first time he understood what this ICER is and how do we understand something is cost effective or not." It was very nice to like hearing somebody from like somebody who's been writing about cost and drugs for a long time. And then also another interview I had was with Forbes magazine. So that was like where I started looking at, oh, this is interesting. As a young faculty, I never thought about my work being highlighted in these leading media. So that gave me confidence also. Okay, this is something that the work people are paying attention to that work. Something of what I'm doing is it seems like I'm on the right track. That was like a reassurance because I was still questioning internally if I'm doing something which is unconventional and being trained in very much in IE, OR, but doing more applied work than most of my friends and colleagues were doing. And I was not sure like if I'm being appreciated or not. These questions were coming at the back of my mind. But these things at the other side were helping me. Okay, this is good. I'm getting some recognition. So that helped in my journey. Okay, so why, if this treatment is highly cost effective, why there is so much fuss about the treatment cost? So this figure will try to explain what's the problem here. So this is showing the overall cost of hepatitis C management by different like screening and treatment. And then this shows that when the drugs were launched, first generation treatments, nationally we were estimating around $9 billion are being spent, but we are seeing a spike in the cost of treatment primarily because of the spendings on the treatment. These were the estimates that we would have to spend about $17 billion a year on hepatitis C treatment. This is overall, putting everything together. We can look at this by different payers. We had that by Medicare, Medicaid, private insurance, uninsured, incarcerated populations, different subcategories. For almost everybody, they did not have enough budget to treat all hepatitis C patients who have been diagnosed, not to mention that people who are not being diagnosed yet. So budget was a big, big issue for almost every payer. And we further show that there's with price reductions, if there's competition that brought price down, this may help a little bit. And we expected that by 2020, majority of patients would have been treated, which unfortunately did not happen. We'll talk about that later. And then the generics will become available in 2030. It's going to be too late at that time. So the question was then, how do we pay for hepatitis C treatment? So that also led to some interesting thought exercises. Can we come up with some innovative mechanisms to achieve eliminate hepatitis C? And one thing we knew that the money spent on hep C elimination, it's a good return on investment because we've seen it's highly cost effective. In fact, at some point it became cost saving also because the prices came down. The treatment became cost saving. What it means is that we can treat people, we're going to extend their lives. At the same time, the society is going to save money or the payer is going to save money, but over the long next 10 years or 15 years, because we would be preventing a liver transplant, which costs $500,000 down the road, 10 years down the road. So by treating now, we're saving those future costs. So that can be cost saving in the long run. But the question that doesn't help answering the question, how do we pay now for the treatment? Because that's big budget. So there's another method that was mentioned, somehow came in the discussions, was the Netflix type approach, which is like subscription-based model, which is something very new for pharmaceutical industry. It's like you have a fixed agreement between the payer, it could be Medicaid, and the pharmaceutical company. Like they're going to pay like fixed amount of money to the pharmaceutical, and then they treat as many people as they can, like a subscription. There's not per price per person treatment cost. So let's say if they pay like $10 million, and it doesn't matter if they treat 100 people or 1,000 people. And the rest of the burden is on Medicaid to treat as many people as possible. This seemed like a win-win situation. And then that also gave us an opportunity to explore further. If this makes sense, under what conditions this kind of mechanism would make sense, where Medicaid and pharmaceuticals should agree to a given price from both perspectives. So that's the work we still like finalizing, and it'll be more like, it also led to some methodological innovations. So that was a motivation, not just the applications in the public health side, but also on the operations side, advancing the methodologies. And this is not my area per se of expertise, so I collaborated with people. Some of you may know these names on the call. So that was my way of interacting more with the IE or community, utilizing the expertise that our people have, and then how we can answer important questions. They're still very relevant and important questions. Okay, so then moving that on from there, my journey started with working with the World Health Organization. I'd like to share a story how this journey started and what things I can tell to junior people like who are starting, would like to explore such collaborations. The most important lesson I learned was we need to get noticed. Means our work needs to get noticed. We need to find our Gaga factor. What is that? For me, what worked was the attention in the media, these high impact publications that were picked by media. So that's how things started getting noticed. It could be for different people. There could be other things. There are different avenues of social media could be another one which people can utilize. Some are very active, others are not, to get their work noticed. Or it could be something else for other people. But that was an important, looking back, was a factor that contributed to these collaborations. But that was not enough. This one also was important, was reaching out to relevant stakeholders and connecting with them. Networking was very important with the right people from those organizations and agencies. And so this was how I started with the WHO. I was a junior faculty at that time, and a senior faculty gave me an advice that when I'm going to conferences, I should try to connect with people from these agencies, CDC, WHO, and then interact with them and see any collaborations. And I reluctantly, little bit hesitant, I sent an email to the director of the Hepatitis C program from the WHO, who was attending this conference, the liver meeting. I was also attending. And then he agreed to meet. We had a few 10 minutes conversation, friendly conversation, and he put me in touch with his team. And then he also mentioned that they were organizing a meeting in Geneva where they had invited a closed door meeting of 20 to 30 people from different parts of the world to discuss the cost, the health economics of hepatitis C screening and treatment, which was very much the topic I've been working on. So I kind of invited myself to that meeting, and then the person, they agreed as an observer, I can attend that meeting, but I won't be able to participate actively. And I have to cover all my expenses, which was fine. Then I had some funding. I went to Geneva. The plan was I'll go there. But before the meeting, the conversation started happening in the email. And the person asked me to give a talk on one of the topics I was working on in Hep C in prisons. So immediately from observer, I became a speaker in that closed door meeting. And by the time I reached there, I had given 2 talks and actively participated in the meeting. Now, looking back, if I had not reached out to that person, the director of the Hep C program, these collaborations may not have started, or I could have started very late in my career. So that was an important finding, the lesson that connecting and also telling them how we can offer something they're looking for. This is my job and my responsibility to tell them that my work can provide a value to what their program is about. So I came from that space, and that helped them build that connection. And then eventually I became very good friends with the director, and then when he visits the country, we often meet if we can. So that's how the collaboration started. But as a junior faculty, I was very hesitant to reach out to somebody and then who's directing this at an agency, which I thought is not within my reach. So that's something I would like to share, that don't, especially the junior people, don't shy away if you think you can provide value to some stakeholders. Could be WHO, could be CDC, could be any payers, any industry. So those connections and those networking help, reaching out helps. And then another lesson I learned was working with the WHO was what we as a community were developing and what versus what policymakers need. And sometimes, or many times, the needs were not, these were not aligning. So it's important to understand what policymakers are really looking for. What they need is something very simple that they can help answer the question. They don't have to explain too many things. And many times they would trust our capabilities, our expertise, but how do we simplify the message, simplify the things that they really need? Because they also have to do their job of explaining these to others within their own realm, which people may not have technical backgrounds. So from that conversation was the work that we have been doing on modeling. We wanted to develop something which is simple, interactive, anybody can use. We call it Hep C calculator. The main idea of this tool was that with different countries, they can enter the data and run the cost effectiveness analysis. They can change certain inputs, and but they cannot change other important variables in the model. But we make it as something very as a graphical user interface, which is more tangible than a slide deck. And we launched it with the WHO, and they loved the tool. And the person was, they would go to different countries, they'll just show the tool, and WHO was working with different agencies, different governments in different countries. They would just show the value of this tool. The main benefit they received was they can convince the government to invest in hepatitis C treatment. They would show that treatment can be cost saving in the country, how much the government can save, and in a way which, and the government also, they may not understand cost effectiveness analysis, but they could at least play with some of the input parameters. What if I change the cost of treatment, cost of screening, if I change the cost of liver transplant, how these would impact the outcomes. So that was the idea of this tool. And then, and the other benefit also was that some governments, they use this tool for price negotiations with the pharmaceutical industry. They could show that, okay, if we can bring the price to this range, it can be cost saving or cost effective. So we are not willing to pay more than X amount of dollars for these treatments. And we also made things very simple, standardized. Run a scenario for a given country. There's a standardized report. You can executive summary, which provides the key inputs and the key outputs that are easy for them to just download and share with any relevant stakeholder. Again, the message was, keep things as simple as possible for stakeholders. That has a big impact and uptake of these tools. And then we extended this to, analysis to, we had more than 100 countries modeled in there. And then showing then how the treatment becomes cost saving and what price ranges in different countries. Okay, so one opportunity leads to another one. So from there, the work with WHO, then from that got CDC's attention, the work we were doing with the World Health Organization. But again, that was not like this. The CDC came and they said, we want to do something similar for the US. It was again, at the networking that helped, and then the convincing. It was, I had to talk with the director of the CDC for hepatitis C in the CDC at that time, and show them the value of the work and what CDC can gain. Again, the burden was up to me to convince the stakeholders. They may not know that always. It's not like they would not know, but many cases they may not see the value of the expertise and the tools, the models that we develop. So it's our job to, again, convince them and show the value. So that's how we led to the development of this new tool we had for each state to inform hepatitis C elimination. So we made it publicly available, direct collaboration with the CDC. We launched the tool, was well received. So the idea was any state can go in there, look at the budget how much budget is needed for them to reduce Hep C burden and eliminate hepatitis C. How much would be the cost on screening, the cost of treatment, plus the cost savings down the road, how many deaths could be avoided, how many liver transplants could be avoided in each state. And then we made this, again, the benefit we saw was that making these tools and data available, accessible to policymakers can have a big impact. And just to give one snippet, an example here is like this was Virginia used, many states used, but Virginia, this was in particular, the chief medical officer, they wanted to use this tool to reduce restrictions on the treatment. Many states had implemented who wouldn't get treatment because they did not have budget. But our tool was showing the value of providing treatment to everybody. They used this tool, and this afterwards, the chief medical officer sent a nice email, which really was it's unusual and was nice to like get that email, like a rare email that saying that this tool made a great impact on their decision-making that helped the committee vote against any restrictions on the treatment. The data shared were very helpful in making the case. So deep thanks and extensive research and rapid turnaround, and made a big difference. This is an example like making these tools accessible, and people started using them and reaching out instead of we going out and showing the value and telling people about this tool. Okay, so moving forward, that also then another lesson learned was, can we identify unique opportunities where we can make an impact with our own research, what we're doing? And this case was an example of hepatitis C in prisons. It was a big problem in hep C in prisons because the prevalence was so high, like 12 to 35% of inmates in the US had hepatitis C, and I'm talking about 5 years back. So it's still very high. It hasn't gone down much. And a big majority of the prisons either offered no screening or very limited testing for hepatitis C. And only a very small fraction of people would get treatment. It's a big problem in prisons. And what was happening in the prison at the same time was these headlines about like prisoners sue Massachusetts for withholding hep C treatment, like inmates with hep C sue Tennessee prisons officials for treatment, not providing treatment. So that kept happening. So what was the situation here? Prisons don't really have budget to treat hepatitis C. So this was like a prison's dilemma. Like, what should I do? Like, they cannot treat everybody. If they don't treat, they get sued. And one sweet spot for them was not to test anyone for hepatitis C, because if they don't test them, they don't know they have hep C. But if they test them, then they are obligated by the laws that they have to treat them. Constitutionally, they have to provide the same care inside the prison that anybody outside the prisons in the society gets. But we, as in the community, knew that it's a really bad situation, because there's a unique opportunity to identify people. These are at high risk. Many people inject drugs. If we don't treat them now, people are released on an average 3 to 5 years is the length of sentence. They're released back in the society. Many people will go back and inject drugs. That's where hep C will continue the transmission in the society. So we wanted to explore if we can generate some evidence showing that by intervening in prisons, the society will benefit in terms of reduction in transmission of disease and in terms of reduction of liver-related deaths from hepatitis C in the society. So that led us to the work where we developed this agent-based simulation model that was simulating the dynamics of people moving in and out of prisons, the sharing of needles, and then hepatitis C disease progression. Not going in any of the methodology details, but the main finding of this work was hep C screening and treatment in prisons reduces incidence and mortality in society. It's obviously there's going to be reduction in the prisons, but the major benefits are happening in the society because hep C is a long disease. It takes several decades, and people get released from prisons in 3 to 5 years. So people would have those adverse outcomes, like somebody may need a liver transplant 10 years down the road when they would be maybe on Medicaid or Medicare. At that time, society would have to anyway take care of that burden, financial burden. So you see that from the plots, the majority of these benefits would be avoided by, or would be availed by the society. Those infections are avoided in those in the general population. So this work was also picked by media. This was I was interviewed at Marketplace on NPR. This is one of the most aired, most listened radio shows. Was again getting a highlight on a topic which was very unique, like prisons and hepatitis C. And we showed that how the society would value. The message was very unique, and the models was also complicated, and a lot of data went into there, and they came up with some nice policy implications. So right after the study was published, the Federal Bureau of Prisons updated their screening guidelines. They changed to universal screening for hepatitis C in all federal prisons. That was a big impact this one study could have on changing the screening policies in prisons. Okay, so, but that was not it. There was still another problem in Hep C in prisons, because even if they are treating people, they don't have enough budget. They start prioritizing patients. But how do they prioritize? Who should get treatment first? There could be many factors, like should we treat more severe patients now because they are at the verge of developing these liver transplant, like end-stage liver disease, or should we treat somebody who is going to be in the prison for long term, for like 10 years, 5 years, versus somebody who's going to be released after 1 year? So these questions came into play. Should we treat somebody who is injecting drugs because they maybe, if we don't treat them, they could be transmitting disease to others once released? Then does that mean that we should be penalizing somebody who has not been injecting drugs? So these are difficult questions. And then we wanted to come up with some solutions here. And then that led to another collaboration where we came up with these closed form solutions using multi-armed bandit model. And we provided some algorithms how prisons should be prioritizing treatment, which would provide best value. And we also, in parallel, developed a decision support tool, simple tool that can be used by any prison system for prioritization. This is another example where an important question also had some methodological challenges, which also advanced the methods in the IEOR space. Okay, so then came the highlight of my career. I would say that this working with the White House, this opportunity, this came last year. So hepatitis, the White House, they had this initiative of eliminating Hep C in the US. And this came directly from an invitation from the White House because they had seen the work we had published in the past, and they wanted to work with us to help them develop their national hepatitis C plan. But they also need to look at the cost and the cost implications. How much would it cost? What would be the cost savings? So this is the person you see in the middle is Dr. Francis Collins, who at that time was until recently was the director of the NIH and was the scientific advisor to President Biden, who is still the champion for this Hep C elimination program. And the right side you see is Dr. John Ward, who is the former director of hepatitis C at the CDC. We were working together on different projects, and we worked with him and the CDC at that time. So what the White House really needed was some numbers to show that what could be the impact of a national hepatitis C elimination program. And these are some numbers like how many deaths can be avoided. We show that by 2050, how many deaths, by 2030, these many deaths can be avoided. But the most important number that they were looking for was the cost. By showing that, if we continue with this is without going into the details, how much is the total spending on the cost for hepatitis C? Treatment, screening, and disease burden on the next 25 years versus the next one is the accelerated scenario for hepatitis C elimination. What they were looking for is the cost savings that would come from them, because this is an important number. They have to go back to the Congress to get budget for starting a new program. That was the important finding. Even like some reflecting back, budget was the key factor which helped with moving things forward. Now we're still working with them. It's still the project is very much in progress. We're fine-tuning the results that would eventually be presented to the Congress to ask for the budget for this national program. And what really helped in this project was the timeliness. We were ready. We had all the tools. We had the numbers. We had the knowledge. The request came. Within 6 months, we had the results that the White House was looking for. So if opportunities come, we have to quickly jump on them. We cannot take years to it's like writing a paper and then revising it and then further improving it, because they have to make decisions very soon, within few months. And we have to be ready. And this is where biggest impact one can imagine with working with such organizations where they're launching these national programs. But they still need to rely on some numbers. So whoever is making decisions has to look at something. Either they have data or they don't have data, or they may have models, they may not have models, but still decision making is required. And if we're ready, if we have done the work and we show the value and reach out to those people, that can have a big impact. The other thing is also important is showing our work to relevant audience. It's great we present our work at the Informs community or other related organizations, but we also have to step out of that comfort zone and present to the audience, to people who are influential. It could be in the medical organization, the conferences and related diseases we work on, all the policy conferences that we work on. And this is an example of the highlight. What you see here is it's a large room with close to 2,000 people in the audience. And the spotlight is that's where I'm presenting our modeling work on hepatitis C treatment at the liver meeting in this presidential plenary session, which is almost exclusively reserved for randomized controlled trials. But this was one of the first times the modeling abstract was accepted at that time. Because the question was important in liver transplant community. So as a junior faculty or as a student, I could never imagine myself presenting to 2,000 physicians in one day. But the opportunity came, and because the questions were important and people were looking for answers, and we could provide those answers. So what I look back is that there may be many opportunities that we may not think about as we are starting our journey, but as we move forward, these things can come, which can really become highlights of our career. And this talk was one of them, actually. All right, so I'll then shift a little bit gears and talk about COVID-19 very quickly, and then we'll pause and soon with have some time for questions. So COVID-19, using our experience in the past, we developed a suite of tools. The idea was keep them as interactive as possible, answer the questions. As you know, with COVID, everything was changing so fast. There was not much time to wrap up things and publish. So we made our tools and data publicly available for stakeholders. And the first tool that we developed was the COVID policy simulator that helped with answering the questions about lifting of restrictions before these vaccines became available, as we were all under the lockdowns. States were opening up, some businesses were open, others were closed. Other tool was the outbreak tool. I'll show some example here. And then they've also developed some fun work on football tracker, where games were happening, if the COVID is spreading or not. And there was another tool which is now less relevant. And some of the highlights, what our medium of dissemination of COVID work was through media. We would make press releases, and anything we put out there was immediately picked up by media. And this is an example of from the Rachel Maddow show on MSNBC, where she took 5 minutes to describe our interactive tool, how this can be used by different stakeholders to answer questions about opening and closing of different states. Here's another screenshot of the governor of Massachusetts at that time, Charlie Baker, was being asked how their policies. That time, Mass was thinking of opening these states, and our model was showing the spike in the cases, the restrictions are lifted. The reporter was asking how the policies are being aligned with the simulator. And this is another one from the Georgia governor. Georgia was one of the first states to lift all restrictions. Our model was showing it's expecting a spike, and it did happen after that. So the reporter was questioned the policies with respect to how the governors made this decision. And the tools are also frequently featured in the NPR and the Newsweek, showing the findings. And this is an example of one tool, the outbreak tool, where we showed where the outbreaks were happening in different counties. So this is different from the hotspots that New York Times was publishing, which New York Times was mainly looking at where the caseload is high or low. But what we were projecting was where the disease is spreading faster in terms of the doubling time. If which counties have the lowest doubling time means the fire is spreading fast, rapidly in those counties. And can we intervene at that time to stop them? And this is just I think the video that shows that we had we projected these doubling times. And this is just a video showing how over time, starting from 2020 onwards, we're still updating this every week, how the doubling time is changing in each community. You see that now this is at some point, it became very red. That's when the Omicron hit. and then again was quiet. Again, we started seeing some happening. This is the latest one, we in 2022 end. And this is the almost the end of, this is the latest tipping time. We can still keep seeing some outbreaks happening, but this is of less interest now because people have learned to live with COVID. These outbreaks don't have a big impact. But this tool was very helpful in the early days and before the vaccines, and the uptake was high. And to develop this tool, let me see, okay. So this is also, there's an interesting methodological challenge in this work. We utilize multiple data sets and machine learning, and especially using generalized random forest to look at we also learned from the different counties, not only this county, but other similar counties. We had to identify on simultaneously which are the other similar counties we can learn from and how much back we should go in predicting what is coming next. There's also a sweet spot. We cannot go too far in the history, but and in the last 2 weeks or last 4 weeks, there's this window shifting. So there was some interesting methodological contribution, and we still like finalizing this paper, which will be going into the ORMS field. We also had some fun. This was the football, many fans, maybe on this call also. So this was happening in 2020 season, that some games were allowed in person, others were not. So this gave us an opportunity to do quasi experiment to see if with games, the counties which are allowing football attendance, were they contributing to spread of the COVID or not? Because the main finding was that actually the football games with reduced capacity did not cause any uptick in the COVID at that time. So that was a nice finding that was good for football fans. So coming to almost towards the end, what is something that it's my personal opinion is that the question is how can we, so for me, the high impact works were easier because I was in the medical space. I was working in the medical school in the public health space. But for somebody who's working as a faculty in IE or department, is there anything we can do to incentivize people to take on the high impact work, the application work? And some reflections from my side, just observing what I've heard from my colleagues. Is one of the most important thing is how do we balance those impact work with the tenure and promotion criteria? If you just want to look at how many publications somebody has in ORMS or A journals and IE journals, then that defeats the purpose. Then people are not incentivized to take high impact publications, which may not necessarily go into those top ORMS journals, but may have high impact otherwise. That maybe this is something that as people on this call who have the power to make any influence in the promotions and tenure, something to reflect on. There could be different tracks. Maybe there could be one track for that's the traditional track. There could be another track for high impact work where other non-traditional publications get heavily credit for that. Also, like where should we publish? Then these are like typical like top journals, but there are the medical journals. Like we publish like things like in Nature, Lancet, and New England Journal of Medicine. These are very high impact journals and read by the policymakers and the stakeholders. Whereas rarely somebody in the policy space or from the politics or policy would read any of these journals on the left side. So how do we convey the message to the end user of who's of our interest? And how can we incentivize faculty or students to publish in these journals on the right side, which can have high impact, but does not jeopardize their chances of getting a promotion or a tenure or getting an academic job in ORIE field. Another lesson is the money really is matters, like grants. Like there's a lot of funding from the NIH for some modeling work. NSF also has some funding mechanisms. And the more such mechanisms we have, more incentive people would have to work on high impact publications. And speaking of that, this is where I'm almost ending. I would acknowledge the funding I've received over the years from different agencies, including the CDC, NIH, NSF, and World Health Organization on these different projects. So all of these contributions that I'm talking today, that's a huge contributions came from many students. In fact, most of the work that I'm presenting heavy lifting was done by students and in different capacities, postdoc, data analysts, undergrads, grad students, and collaborators and across the IE Informs community. So I'm very thankful for the support and a lot of fun collaborations with them. Again, I like to end my talk with this question. This is an important question, why I'm doing what I'm doing. It's a reflection for us to think about if we want to change anything in our trajectory. And we have to be very honest. If we don't like the answer, that's the honest answer, then how do we change the path if we don't like it? With that, I'll thank you all for your attention. That's all I had for today. I'm happy to answer any questions.
Great, very nice talk, Jag. Thank you so much. So there is a Q&A box if anyone would like to provide questions. So maybe I'll give it a few seconds here to see if any questions pop in the chat. And I guess in the meantime, maybe I'll start with one. So you mentioned, developing these interactive tools is very helpful for communicating your work and especially keeping it simple. So I'm wondering maybe what other lessons along the way you've learned to kind of communicate to people who maybe are hesitant about the idea of using a model, or, especially with COVID, uncertainty in models, how to kind of balance or maintain that buy-in. So yeah, any lessons you have on that front?
Yes, yeah. So I feel the silver lining of COVID for the OR MS community is that we don't need to explain what we do. We say we do modeling, and most people get it, disease modeling or in the health application modeling. Earlier, it was kind of sometimes a bit of a challenge to describe what models we do, what is the use of this models. But with COVID, the general audience became acquainted with the usefulness of such models. But also, to your question, that it's also the skepticism is there, because many of these models can lead to different outcomes. Like there's a huge uncertainty, and then showing the ways, like, and many times we can use these models to use these models for what if type analysis rather than as something we're projecting is going to happen in the future.
Mm-hmm.
With COVID, that was the big problem. Most people were seeing this as, oh, the model is predicting this is going to happen, but this did not happen. No, it was not that. The model was saying, under these conditions, this will happen. Under that conditions, that can happen.
Mm-hmm.
So that communication was important.
Great.
And another thing I learned was that people who were skeptical to modeling work, they became less skeptical after interacting with the models. They felt like they had some ownership and stake in that. And this was more tangible than just looking at a PowerPoint, a bunch of results and equations. Somehow the people were more open to accepting the results of the models when they can interact with them.
Right. It seems that they have some sense that, okay, the model is doing what I would expect, I suppose. Great. So we have a couple of questions in the chat. So one question is, from my experience, decision makers in the pandemic relied heavily on economists and epidemiologists, but not as much on decision scientists. How can we be more relevant in practice?
Yes, and this is where I think one is we have to make ourselves visible to the stakeholders. That's important. The economists are very heavily integrated with the policymaker, so it's natural for the decision maker, like from the government's office, they would reach out to the economist, but not necessarily to the decision scientists, because they don't even know what we do. So that as a society, we have to make our work more visible, more relevant to practice, and then more visibility of our work has more connections. More people will think about decision scientists. And I feel this, my personal, obviously I'm biased, is that we have been trained to make these decisions. We have been trained through our education, how do we build models, how do we optimize the decisions. That's our job. Whereas other fields, they are not trained for these kinds of things. I feel that we are the best people to answer many of these questions, like COVID and then different questions of the decisions and other policies. And more we step up and show the value of our work, more visibility it will get.
Mm-hmm. Great. So there's another question, or a few more, but how would you handle it when the details of parameters change the outputs? How do you communicate with policyholder or policymakers about the uncertainty of predictions based on the minor details of design in the models?
Yeah, I think this again depends upon how much the stakeholders are familiar with how much modeling savvy they are. If they are, then they would understand doing these typical sensitivity analysis and showing when decisions can change because of uncertainty. I don't know. That's all I can think of. Like more we can show, depending on where they are, we have to go to their level and explain to them the impact of uncertainty.
Great. Another question is, so in the development of models, there always seems to be a trade-off between sophistication and explainability. Could you share your experience with this, especially in communicating your work to practitioners and policymakers?
Yeah, that's a good question. My approach has been less is more. Less details we provide, it's easier for others. Whereas if we provide more details, they may get lost into those details. But it's still our job to make sure that we have enough sophistication in our models and that they're providing reliable outcomes or results.
Great. All right. So that's our questions in the chat. Feel free to keep providing them. I'll ask another one that I'm interested in. So for this hepatitis C work, I noticed that you kind of transitioned into focusing on prisons. So how did that focus come into play, or, kind of building up that pipeline in terms of working with prisons or getting data? Could you talk about kind of how that piece of the project started up?
Yeah. It happened that talking with the collaborators that this was coming up again and again. This Hep C was a big problem in prisons, and there were many challenging questions about treatment. Now there's an opportunity, but the problems exist. How do we solve that problem? So that's from there it started. And we had collaborators who worked with prisons very closely in prisons. So we worked with the several directors of the prisons in different states to get data. And I do have to mention that it's not easy to work in settings like correctional settings because data could be challenging. Funding could also be problematic. It's not easy to get funding. So those things to keep in mind. But whereas the impact can be very high, it's very unique opportunities for us where we can contribute and address some of the problems.
All right, well, I believe we're right about at time, so just be respectful of people trying to get on their 2 o'clock call. Maybe we can leave it there, but thank you again, Jag, for the great talk. Yes, and I believe our next one will be at the end of last Friday of March, so we'll send out more communications then. Thank you everyone for joining, and thank you again, Jag.
Thank you, Lauren, for the invitation.